Today's lecture is on adrenal disorders. Is second of the series of the lectures on adrenal uh, diseases, and we'll discuss it in case scenario format as usual. So, this is a case of a 32-year-old female who had consulted her physician for primary reason of being overweight and obese, and this obesity has been of recent onset. She has been having a very smart figure previously. She also complains of fatigue, low back pain, also noticed some increased thirst, and reports that her facial hair has increased in recent past. On examination, she has a rounded faces. She's weighing 96 kilograms. Her blood pressure was 160 over 95 millimeter of mercury. Her abdomen was protuberant, and there were some purplish stria over the trunk and the flanks. This was the on examination her abdomen it looked like, and these purplish stria, which were quite diagnostic of or very suggestive of an underlying adrenal disorders, can be seen in other cases as well. But why this stria happen, that when you have a skin of the abdomen or of the thighs being stretched because of the initial weight gain, and then when the underlying fat and soft tissue that is thinned out, the capillaries become visible, and this give a reddish or purplish hue to the skin, the stretched skin in the those stria. And this is can be seen in many cases. The white stria, they are seen in women after pregnancy, when the abdominal skin after pregnancy distended abdomen do have those wrinkles or stria, which is called stria gravidum. It can happen in those who lose weight to a great extent, and then this purplish stria are usually a feature of adrenal disorders or hypercortisolism. Now, the diagnosis in this case to be suspected is Cushing's syndrome. What it is, this is what we'll be talking about in next few slides. Now, Cushing's syndrome is a constellation of clinical abnormalities due to chronic exposure to excess of the cortisol and related corticosteroids. And cortisol, as we know, is the main hormone produced by adrenal cortex, and it is regulated through a feedback mechanism from the pituitary and the hypothalamus. Whenever you have an increased cortisol circulating in your body, it affects all the three metabolic pathways. On first of all, it would lead on to a lot of lipid mobilization from the periphery to the center. It would lead on to increased catabolism of the fats or lipid catabolism. This would lead on to a redistribution of fats, and this fat which is moved from the periphery is deposited more around faces, giving it some more faces, around the hump or back of the neck, which giving it a buffalo hump appearance. It is deposited mainly around the trunk, abdomen, and the back, and then there may be lead on to this excessive stretch may lead on to villaceous stria over there. This cortisol also affects the glucose metabolism. So there is an increased gluconeogenesis or increased production of glucose from the liver, and this excessive glucose also leads on to some degree of insulin resistance, and the patient develops glucose intolerance and may develop frank diabetes as well. Similarly, the hypercortisolism affects the protein metabolism, primarily in the form of a negative calorie balance or negative nitrogen balance, and resulting in more protein being broken down to make more of fat. And this there's also disruption of water and electrolytes metabolism. Now, the protein say catabolism or negative nitrogen balance would lead to proximal muscle weakness, and patient would have difficulty in complain of difficulty in standing from a sitting position or raising his arm above the head. The disruption of water and electrolyte metabolism because this cortisol does have a little bit of a mineralocorticoid or salt retaining properties as well. This is then results in dependent edema. This may also lead on to activation of renin-angiotensin system, leading on to hypertension, and similarly the hypokalemic metabolic alkalosis, because more potassium would be lost in the urine, and there would be more retention of sodium, leading on to both hypertension and fluid retention. Now, this is the pathogenic mechanism of how hypercortisolism has its effect on the body through the effect on the various metabolic pathways. When we translate that into how it would affect the patient, or what would be the features on physical examination of these patients, then we can say the weight gain is seen almost in 90% of the patients. Moon faces is usually in 75% of the patients. 65% of the patient who develop this Cushing syndrome or hypercortisolism may have this tria. Hirsutism again in 65%, glucose intolerance around 65%, proximuscle weakness is seen in 60%, the gain reddish hue or plethora maybe 60%. 60% of women may complain of menstrual irregularities in the form of both menorrhagia or maybe oligomenorrhea. Acne is seen in more commonly in women, easy bruisability, osteopenia, dependent edema, hyperpigmentation, and hypokalemic metabolic alkalosis. All these features are seen in various frequencies or various proportions. This is the classical appearance of both in the form of a real time appearance or maybe in the form of a cartoon. That this is what we call as the rounded faces or moon faces. Their hoods and increased hair growth. These hair are usually darker and more commonly seen in women. This back becomes a hump or hunchback like in buffalo hump. There is an increased frequency of bone softening or osteoporosis and increased tendency of fractures. The tissues do get hypertrophy, and this they may have both as a result of hypertension or again increased tissue deposition lead on to hypertrophy there. Heart muscles, they tend to get obese. They do have abdominal striae. I did mention women may complain of amenorrhea, and then their skin usually is very soft and very fragile and easy to bruise and easy to rupture, and then there will be wasting of the muscle. This is another lateral profile of a patient. You can notice this buffalo hump. You can also notice this increased excessive hairs and some degree of course, moon faces is not, and this again the deposition of fat around the neck. Again, a lateral profile, and the noticeable thing is that all the things are the obesity or all that is all around the trunk or center. And if you notice these limbs, they are relatively thin. So relatively more truncal obesity and more wasting of the periphery. That's what gives it to a very peculiar type of appearance, which is called as a lemon and matchstick. You might have played like that you take a lemon and you insert the matchsticks into it, making them as looking like limbs, and you make it. It's like a say human or appearance. But what is noticeable that the limbs, they are very thin, the abdomen and trunk is very obese, and that's what this appearance of lemon and matchstick is usually seen in patients with advanced Cushing's or hypercortisolism. This is the increased pigmentation, again seen in particularly in patients who are having this disease because of increased ACTH production from the pituitary. Now, before we talk about that, what is how this syndrome is brought about, we probably have to go back to learn the feedback mechanism for the regulation of cortisol or these hormones. Now, hypothalamus produces corticotrophin releasing hormones. This corticotrophin releasing hormone has a positive effect onto the anterior pituitary to release uh, adrenal corticotrophic hormone. This adrenal corticotrophic hormone on, leads on to stimulation of the adrenal cortex to produce cortisol. And similarly, at the same time, this in ACTH does have an inhibitory effect onto the hypothalamus, leading on to suppression of the cortical, so that the cortisol production is not in excess. The cortisol, again, the both ACTH as well as cortisol, which is produced from the adrenal cortex, do have a negative feedback mechanism or a suppression of the cortical, and that's how this system is regulated. What leads on to an increased, say, stimulation of hypothalamus and increased release of corticotrophin releasing hormone. These are mainly the physical stress, emotional stress, hypoglycemia, cold exposure and pain. Now, all these factors, which are various kind of stresses, they lead on to a stimulation of the hypothalamus, and in return the increased corticotrophin releasing hormone. So we can notice that this adrenal cortex can produce more cortisol either under the effect of the ACTH or due to the physiological demands, and something may go wrong with the adrenal cortex itself, that it start producing more cortisol as a result of any adenomatous growth or something. So the ACTH is produced by the pituitary gland. It is released into the petrosal sinuses around the pituitary, and then there from these venous sinuses it is released into the circulation, and then when it reaches the uh, cortex, adrenal glands, it leads on to release of cortisol. When stimulated by the ACTH, the adrenal gland secretes cortisol and other steroid hormones. Now, what can lead on to an increased cortisol production? It can be either because of an increased ACTH or because of the endogenous production by the adrenal itself. Now, the ACTH dependent causes of increased cortisol production includes ACTH secreting pituitary tumors, like this is classically called as Cushing disease by the name of the scientist who first described it. Similarly, the pituitary corticotrophin releasing hormone secreting neoplasm this would be ectopic corticotrophin releasing hormones. That pituitary itself does have say corticotrophin releasing hormone, and this in return leads on to increased ACTH production. Now, this ACTH can be produced from non-pituitary sources as well. So there are various neoplasms which outside the pituitary in other parts of the body, whether they are in the lung or say in the ovaries or in the other tissues, they can lead on to ACTH production. Now this ACTH would be called as an ectopic ACTH, and this ectopic ACTH of course would lead on to stimulation of the adrenal glands to produce more cortisol. Then there are ACTH independent causes. The similar adrenal gland may have an say adenoma which is not under the control of ACTH, and it starts secreting or producing more cortisol. Similarly, adrenal carcinoma or macronidal adrenal disease, there's a syndrome by the name of McCone-Albright syndrome, where there is an increased production of this cortisol, and then sometimes massive macronidal adrenal disease can also be a reason for increased cortisol production, which would be independent of ACTH. Pseudo-Cushing syndrome refers to fictitious or surreptitious glucocorticoid administration, as we give steroids for various ailments, like for the treatment of asthma, for treatment of joint diseases, for treatment of various hematological disorders. Now, if this cortisol from the outside source or as a therapeutic agent is given in excess, the excess of this would also produce Cushingoid features, and this is called then either iatrogenic Cushing or a pseudo Cushing syndrome. Talking of the non-pituitary or ectopic ACTH secretion, majority of this is produced from the small cell lung carcinoma. Almost 50% of them, they are from the uh, small cell lung carcinomas. Other endocrine tumors of foregut region, which may include thymic carcinoid or islet tumors, or medullary carcinothyroid or bronchial carcinoid, they constitute something around 35% of the ectopic ACTH production. Sometimes pheochromocytoma, which is again adrenal medullary tumor, can be associated with increased ACTH production as well in 5% patients, and ovarian, as we said, is quite rare, but the 2% of the cases can be because of that. How do we diagnose Cushing disease or hypercortisolism? It is by clinical manifestation as already described, and then there are lab findings. The lab findings, of course, would be that you demonstrate an elevated cortisol level, and you also demonstrate that the cortisol level follows a circadian rhythm, that in the early morning there is an increased demand for the cortisol, so the early morning cortisol is high, and by the time in the evening or around 8 p.m. the cortisol level is low. But once there is an increased cortisol production, either because of the uh, ACTH dependent or maybe dependent, this circadian rhythm is lost, and you may have equally elevated level of plasma cortisol both in the morning as well as in the evening. The cortisol is metabolized in tissues in liver, and then this is converted into 17-dehydroxycorticosteroid, which are excreted in the urine. So whenever there is an increased cortisol production, there would be an increased 17-hydroxycorticosteroids in urine as well, and they can be taken as a screening test and measured. Similarly, 17 ketosteroids can be elevated, and more importantly, you probably have to go for plasma ACTH to look for that. If it is cortisol is of an adrenal origin, the ACTH would be suppressed. But if it is of pituitary origin, then the ACTH would be increased. That's how we differentiate that this is an ACTH dependent cortisol increase or ACTH independent cortisol increase. The most of the time, whenever you are dealing with in endocrine disorders, dealing with an excess of hormone, these hormones lose their feedback mechanisms, and they cannot be suppressed. So this is again for the cortisol producing adrenal diseases. You try to suppress them. How do we do that? We can do a screening test of trying to suppress the cortisol production. If you give someone 1 milligram of dexamethasone at night, midnight, and next morning you check initially basal cortisol level before giving dexamethasone, then you give the patient 1 milligram of dexamethasone at night, and next morning at 7-8 a.m. you check the plasma cortisol level. Now, if this gland is under the effect of the ACTH dependent pathway, the exogenous dexamethasone would lead on to suppression of ACTH, and this suppression ACTH would lead on to decrease in the production of cortisol, and with lower patient would have a lower cortisol level in early morning, and if you compare it with the previous days before giving dexamethasone, it would be lower. So if cortisol is suppressed by giving 1 milligram dexamethasone at night and measuring the cortisol level in the morning, this patient is normal. But if it is not suppressed, then this patient is likely to have a Cushing syndrome. Another way of doing it is by doing a low dose dexamethasone suppression test. In low dose suppression test, you give dexamethasone 0.5 milligram every 6 hours for 2 days, right? 0.5 milligram every 6 hours for 2 days, and you check the urinary free cortisol level before start of the test, and then 48 hours after completion of this 8 doses of 0.5 milligram dexamethasone. And the normal response should be that urinary free cortisol should decrease as a result of exogenous administration of dexamethasone. But if urinary free cortisol is not decreased, this again confirms that patient has a Cushing syndrome. Sometime to differentiate between that this suppression is under the effect of the pituitary or from an it is not suppressed, because then to differentiate it from exogenous say production or production of the cortisol from the adrenal cortex itself, you go for a large dose dexamethasone suppression test. Here the 2 milligram dose of dexamethasone is given every 6 hourly for 2 days, and the results are interpreted that if urinary cortisol, free cortisol is reduced by 50% of the baseline, this is Cushing disease or Cushing disease of pituitary region or pituitary adenoma. But if urinary cortisol is not reduced by 50% or less than 50%, then it can be because of the adrenal tumor, carcinoma, or ectopic ACTH syndrome, because these 3 or 4 say conditions, they are say out of the control of this pituitary region ACTH. Sometimes we can also use ACTH stimulation tests. You give ACTH 25 units intravenously 8 hourly, and there should be a 2 to 5 fold increase in urinary free cortisol if it is under the effect of the pituitary. But if it is because of adrenal carcinoma, this would not lead on to any increase in cortisol level under the effect of the ACTH. Corticotrophin releasing hormone similarly can be used for say assessing the pituitary adrenal axis. So sometimes you combine this corticotrophin releasing hormone with the dexamethasone suppression test, that you give 1 microgram per kilogram of corticotrophin releasing hormone intravenously, and you check the ACTH cortisol levels before corticotrophin releasing hormone, and 15, 30, 45, 90, or every 15 minutes after the injection. So if the cortisol level rises by 20% more above the basal value, or a rise in ACTH value of at least 50% above the basal value, is considered that this is an ACTH dependent lesion. But if not, then we think of an ACTH independent or an ectopic ACTH production, or endogenous adrenal gland production. Metarapan again is an agent. If you give it 2 to 3 gram or 30 milligram per kg per milliliter at midnight, and next morning you check the plasma cortisol 17 hydroxycorticosteroids or 11 deoxycortisol above basal levels, this would confirm the presence of Cushing disease of pituitary region. But in adrenal carcinoma, tumor, ectopic ACTH, you cannot suppress it, and there will be no response. Then if you are thinking pituitary as a cause of an ACTH production and Cushing disease, then of course you would like to visualize on imaging that the pituitary fossa is widened and pituitary gland is enlarged, and this can be seen by a pituitary CT scan, and about 50% of the microadenomas can be picked up, but smaller pituitary tumor may be missed on CT, and you may have to go for an MRI to look for small microadenoma responsible for an ACTH production, and then consequently an increased cortisol production. If your diagnosis is in doubt and you are unable to detect very small pituitary adenoma, the bilateral inferior petrosal sinus sampling for ACTH can be undertaken, and of course, if you detect it in the petrosal sinus that ACTH level is high there, then it confirms that the ACTH is of pituitary source rather than of ectopic source. If the adrenal pathology is suspected as a cause of high cortisol secretions, then ultrasound may be of help. It would be investigation of first choice, but again, some small tumor or small adenomas may be missed, then abdominal CT would have a better investigation to look for the adrenal pathology. Somatostatin is taken up by the say dividing cells and those which produce cortisol, and somatostatin scintigraphy or scanning can be helpful in detecting the ectopic ACTH production, and similarly it can possibly be either used for screening as well as for after the treatment. You may detect the residual or remaining tissues elsewhere in the body which would be taking up somatostatin preferentially. We can have an etiological diagnosis based on certain features like Cushing disease, which is usually slowly developing. Chronic features develop slowly and can be suppressed by large dose test. Dexamethasone suppression test, which we said was 2 milligram every 6 hourly for 2 days, followed by an estimation of cortisol or urinary cortisol hydrocorticosteroid secretions. The adrenal adenoma, on the contrary, have a very short course. They would appear within few days or weeks. Features are usually mild, but this again cannot be suppressed by large dose test. It is not under the effect of pituitary, so that's why that dexamethasone suppression test would not be able to suppress it. The adrenal carcinoma again are very abrupt and rapid in onset. Their course is very progressive. They also have other hyperandrogenic effects, and there may be sometimes mass may be palpable, but the ACTH would be low because the excessive cortisol production from the adrenal carcinoma would lead on to suppression of the pituitary to produce ACTH. And when you talk of ectopic ACTH syndrome, they appear suddenly in setting of an underlying malignancy or bronchogenic carcinoma. They are very rapidly progressive. They don't show the typical manifestation of Cushing syndrome. The hyperpigmentation, hypokalemia, and high ACTH are usual features of these ectopic ACTH syndromes. The differential diagnosis of Cushing disease or Cushing syndrome includes a simple obesity, general obesity, long history, patients are overnourished, they usually have maybe narrow and short stature. Your urinary free cortisol can be suppressed by screening overnight test and or by low dose dexamethasone suppression test. There is a normal diurnal rhythm, and the plasma cortisol 4 a.m. reading would be 8 a.m. reading would be slightly higher as compared to the evening readings. Sometimes diabetes can be confused with the Cushing syndrome because of both may have a hyperglycemia as a common feature. So in diabetes, the plasma cortisol level and rhythm both are normal, and once you control the blood glucose, the urinary cortisol usually returns to normal. Those who are alcoholic, they can also have a Cushingoid appearance, but if you ask them to abstain from drinking for a week and then check their plasma cortisol and urinary cortisol levels, they would become normal. Depression again can lead on to picture similar to Cushing, with sometimes they have hyperphagic, they gain weight as well, but again the other features of Cushing syndromes are missing. How do we treat them? Cushing disease, which is because of the pituitary adenoma or ACTH producing pituitary adenoma, is dealt through transfenoidal microadenectomy or pituitary radiation. Sometimes you go for bilateral adrenalectomy because if the pituitary tumor is, say, cannot be managed through uh, surgical approach alone, and sometimes you go use certain drugs which decrease the production of cortisol from the adrenals. The adrenal adenomas or carcinoma, of course, would require surgical removal. You can use drugs like mitotain, metarapine, ketoconazole for non-resectable or metastatic adrenal tumors. Ectopic ACTH syndrome, you would require surgical removal of the primary tumor or the ectopic tumor, and it has to be dealt with chemotherapy or radiotherapy. And when there is a widespread, say, metastasis, and which cannot be dealt with surgically, then the drugs like mitotain or metarapine and ketoconazole can be administered to reduce the synthesis of the cortisol or steroid hormones. Cushing disease, as we said, surgical treatment, transfemoral surgery for elective removal of the pituitary adenoma. The bilateral adrenectomy in patients who have, say, non-operable or inoperable pituitary tumors. Now, if bilateral adrenectomy is done for the pituitary adenoma-dependent Cushing syndrome, it will lead on to excessive growth of the adenoma due to lack of negative feedback mechanism provided by the raised cortisol. So this may lead on to Nelson syndrome. By that we mean that you have undertaken adrenalectomy. Now the adrenals were producing this cortisol, and cortisol was the reason to suppress the ACTH or corticotrophin releasing hormone. And this absence of cortisol would lead on to an increase in corticotrophin releasing hormone, and in fact may lead on to an increased growth of the pituitary adenoma by itself. So aggressive pituitary macroadenoma and very high ACTH levels would cause pigmentation, and can be prevented by that you initially irradiate the pituitary gland so that it does not go say excessively say enlarged as a result of increased ACTH when the cortisol would be uh, reduced when adrenalectomy has been undertaken. The adrenal tumors would most of them can be approached through laparoscopic removal. Adrenal carcinoma, of course, would be treated with resection, irradiation, or carcinoma followed by cytotoxic chemotherapy. Localized tumors which are responsible for ACTH, ectopic ACTH syndrome, can be removed. For example, bronchial carcinoid, but a widespread source of ACTH would require the medical management. The medical therapy for Cushing disease usually is that you have to correct the metabolic envelope before attempted surgical cure, or it may have just a palliative, say, role, or if your patient is suffering from a surgically non-curable disease, or you may achieve remission in patients for whom surgery is unlikely to achieve satisfactory long-term results. The drugs like those which lead on to inhibition of steroidogenic, say, hormone or suppression of the ACTH, mitotain or metarapine or amino glutathione or ketoconazole, which is an antifungal, they do have this role of reduced production of this cortisol. Neuromodulatory treatment in the form of for pituitary adenoma like bromocriptine or cyproheptadine and valproic acid, octreotide, or glucocorticoid receptor antagonist like RU486, they can be tried in patients who are otherwise inoperable. The second case scenario is a 36-year-old female who was referred with the oligomenorrhea and hirsutism and weight gain. She also noticed excessive hair on her face, arms, and legs. She was on Hakim medication for asthma, and on examination, she has excessive acne and facial hair. Her blood pressure is 160/100. This was the lateral profile of her. You can notice the excessive hair growth on the face and this acne. What's the diagnosis? The diagnosis is iatrogenic version. This lady possibly has been on steroids by Hakim for the treatment of asthma, and this iatrogenic. On the iatrogenic question, the usual say this would be having a low ACTH and high cortisol, and of course the treatment is that you withdraw the steroids. That's all for today, and we'll be talking up next time another lecture on this adrenal disorders.